Hello, everyone. Let's get started. Thank you so much for being with us today. I am Cassidy Avila, and I am happy to welcome you to Advancing Rural Maternal Health Through Collaboration and Innovation. This is our November webinar for the Texas A&M Rural Engagement Program. Just a couple of quick things before we begin. We are recording the webinar, and we will send out a follow-up email. With the holidays being this week, we might be a little delayed, but you will receive an email with a copy of the slides as well as a link to the recording of today's presentation. So you can be looking for that. Following the presentation, we'll open the floor for a Q&A session, and you're welcome to submit questions at any time in the chat, either to me directly or to the group, but we will hold the questions until the end during that Q&A time. So now it is my pleasure to introduce our speaker today, Dr. Jacqueline Alvarado. Dr. Alvarado serves as the director of the Maternal Health Program at the Texas A&M Rural and Community Health Institute. In this role, she leads statewide initiatives focused on improving access to maternal health care, strengthening rural workforce, and enhancing quality and safety through simulation-based training and the integration of telehealth. Dr. Alvarado is a fellow of the American College of Nurse Midwives and has been nationally recognized for her leadership in rural maternal health innovation. She's dedicated to advancing equitable care for all women, especially those in underserved and rural communities. So I'm honored to welcome her today, and I will turn it over to you now. Thanks, Dr. Alvarado.
Good morning or good afternoon now. Thank you so much for allowing me to lead this webinar to just talk about the things that we're doing on the RCHI side for rural maternal health. So just to get started, basically, I'm going to give an overview of the programs that we're leading, and then I'm also going to discuss some of the simulations trainings that we are currently doing, discuss our OB service line evaluations, and our telehealth program that we are also doing at RCHI. And then just a couple of ideas of how you can reach out to us if you are interested in anything rural maternal health for any of your facilities, and just any collaborative strategies that we can work together for your facilities. So as you probably know, across the United States, rural women are at about 60% higher risk of maternal death, just because they do not have access to the same resources as women in urban areas. There's an increase in maternity care deserts. About 50% of rural counties across the United States are considered maternity care deserts, which mean they don't have any OB hospital services or any birthing facilities. Women that are in rural areas travel over, on average, about 100 miles more to get to an OB facility than urban women. There is an increase in workforce shortages, so there are no OB providers, nurses, midwives in these areas. And of course, that will lead to ultimately higher health disparities for these women. And in these emergency situations for pregnant women, there's an increase in delay of care. So there's a higher risk of postpartum hemorrhage, hypertensive crisis, and preterm deliveries. And so really, we are at RCHI just trying to find an opportunity to increase a larger impact for these women. So specific to Texas, about 47%, so almost half of our state is considered a maternity care desert. And so as you can see here, just based on the graphic from March of Dimes, all of the red are considered deserts. And so they do not have an OB facility. So for especially like the West Texas side, they're traveling pretty far to receive care and to deliver their baby. About 20% of these women received inadequate or no prenatal care because they're having to travel so far. 28% of these rural moms live about 30 minutes or more from a maternal health facility. So they're having to go pretty far just to access care. Specific March of Dimes data, they've dug in and realized that out of the 214 Texas counties, primary care is also a big issue. So about 74% of women are not able to even just get the basic primary care that they need before they get pregnant. So RCHI, our innovative solution strategies, we really are focusing on 5 areas: access, policy, integration, workforce, and equity. So access, we are looking at ways to increasing options for telehealth. We are looking at remote patient monitoring, From the policy side, we're looking more at maternal assessment, service line audits, quality metrics, and just really also at the legislative level of how we can advocate for these women. Integration, looking at a more collaborative model, looking at incorporating emergency room simulations and community health workers because they are, more boots on the ground with these moms. And then workforce, we're looking at ways that we can increase maybe clinical tracks, recruitment for these rural areas. And then last, it's equity, making sure that these OB service lines are getting reimbursed for the same services for this for these women as compared to urban areas. So again, our main three initiatives that we started is OB emergency simulation, prenatal telehealth, and then OB service line evaluations. So really in our rural EDs and our clinics, they are the first point of contact for many women. So we noticed that even though they may not come into contact with emergencies as often as urban areas, we want to make sure that they are still getting the training that they need, even though it is a low exposure frequency, those emergencies are occurring. And they have limited resources. So as I've gone into these communities, they have shortage of blood products. They don't even have the basic equipment to deliver a baby, let alone handle an emergency. The next thing is staffing constraints. Often these emergency rooms are staffing one provider, one nurse. So going through and just making sure that we can put into place just the basic staffing to care for women as well. And then transfer delays is another issue that I've noticed in these communities, that getting these women to the area that they need for that high level of care is really important. So I'm going to dive more into the OB emergency simulation that we've done and are currently offering as the RCHI service. So why simulation is needed? As you probably know, again, OB emergencies are rare, but they can be catastrophic. So making sure that we just practice the skills that are needed in case these women do present to the emergency room, and then stabilize them enough to transfer them to a higher facility of care. It's great because it's, very team-based, evidence-based. We practice clear role identification, rapid escalation, and then effective handoff. We provide it just to be a safe learning space. That way we can make those mistakes and learn from them, bridge those gaps between what they think they're supposed to do and really for their setting, what's actually going to happen in a under-resourced setting. So we developed a simulation model curriculum at RCHI. It is specifically designed for small rural emergency rooms or labor and deliveries that have very low volume, less than 100 deliveries a year. And we truly tailor it to be very practical, scalable, and affordable based on these institutions. And we then offer an on-site in-person simulation training and then offer quarterly refreshers virtually. So this is just an example of what our curriculum looks like. It's about a 100-page document going over basic normal vaginal delivery. We go through hypertensive crisis, postpartum hemorrhage, and we also go over shoulder dystocia. These are the three most common emergencies that are encountered for women. So we go over the pathophysiology, just those refreshers of why this occurs and what needs to happen. We also do pre and post test and evaluations. That way we can really gauge the knowledge, and we want to make sure that the training is truly effective for these emergency rooms. So what we've chosen to do in these rural areas is we get those baseline metrics, and after that, we did a pilot protocol. So we went over normal vaginal delivery, postpartum hemorrhage, shoulder dystocia, hypertensive crisis, and then we also addressed cardiac arrest and pregnancy because we've noticed a lot of the ACLS and BLS models do not address what to do when you have a pregnant patient that does present to the emergency room. So our simulation approach was very low fidelity. So as you can see, this is an example of the Mama Natalie. So we leave each of our emergency rooms with a Mama Natalie mannequin. That way they can practice the simulation with their teams, as well as use this mannequin for the virtual refreshers that we schedule with them. So our pilot was in Mitchell County. This is closest facility for OB is going to be Snyder or Sweetwater, which is about 30 minutes away. We did a 2-day training. It was the same training on 2 different days. That way we could have a good participation. And it was great. We had the CNO, we had the nurses, EMS, and then as you can see, very hands-on, everybody dove in, just getting to practice those basic skills, which was great. So we had 17 participants for our pilot, which was wonderful. We did again a pre and post test at every site. And as you can see from the pre and post test, there was almost a 50% increase in just basic knowledge of what they felt. And it was great to hear the feedback of how relieved they were just to go through these basic hand maneuvers to deliver a baby. While we are there, we also like to go into the emergency room and identify the resources that they have and as well as what's needed. So for this emergency room in Mitchell County, they wanted to build an emergency cart. So we've worked with them to do that. They wanted to apply for grant funding for a baby warmer because this facility is right off of an interstate. They do have a lot of drop-ins. And so that was something great to see that we could build for them. And their first refresher is scheduled in January. Our second training was in Knox County, Knox City, Texas, and it's about 73 miles from Abilene, which is the closest OB facility. Again, a 2-day training, very small, but it was great. We had a high volume of EMS that turned out. And so we had 20 participants for this. And again, based on the pre and post test, their knowledge almost doubled. Their refresher is going to be in February. So we're excited to get these repeat simulations going to really see what they remember and what they've encountered from their first simulation training. Our next one was our first OB service. They actually, in Frio, Texas, they do provide OB services, but very low volume. They do about less than 100 deliveries a year. They're delivered by FMOBs. And so it was good to see that variety of providers that are caring for women, that they still wanted to do this emergency simulation training, although they do deliver babies. And so again, pre and post test, you can see the knowledge increased. And then our last, most recent was in Monahans, Texas, with 14 participants. Closest OB facilities in Odessa, so about 45 minutes to 60 minutes away. They staff one family nurse practitioner in the emergency room and then call someone in if there's an emergency that needs escalation. But we did normal delivery, hands-on. Again, EMS was there. It was wonderful to see. So we have done 4 of these trainings. We have 3 upcoming for first time simulation training in 2026, and we have 4 of those refreshers already scheduled. So very exciting and ready to grow and do more sim training. So really our goal is just to link the hospitals, the EMS, and make sure that they're doing these joint drills. Because we've also noticed that they don't even have protocols in place. So that's the next step that we've started doing, is helping them build emergency guides and protocols for transfer and stabilization of these pregnant moms. The next initiative that we're leading is the Prenatal Care Initiative. So we've devised a program where we're partnering with rural health clinics and FQHCs to care for pregnant women with our APRNs out of our Fort Worth campus. So we have a certified nurse midwife out of the Fort Worth office that will telehealth with women in these maternity care deserts. That's really where our focus is reaching the women that cannot access care, that cannot commute to a clinic or a hospital to see a provider because of the distance. So we've noticed that a lot of these women just choose not to get any prenatal care and they're dropping into the nearest OB facility. So we would like to reduce those numbers of that happening and allow them to seek care with a provider. So they'll see our APRN from conception through about 35 weeks, and then we transfer them to a delivering provider. After delivery, they follow back up with us for their 6-week postpartum up to 1 year. And our goal too is really to provide that wraparound services to make sure that these women are getting connected to WIC, they're getting lactation, they're getting behavioral health, primary care, whatever it is needed for their pregnancy. We want to be able to help them connect with the resources that they need. We also, during these visits, some of these women are higher risk, so we are making sure that they are seeing a maternal fetal medicine specialist They're getting the ultrasounds that they need, the fetal surveillance that they need through remote non-stress test monitoring. So again, just an image of how it would work, partnering as workforce for these clinics, seeing these patients, and then transferring them back after delivery. Our last initiative that we've created is our OB service line evaluation. So for some of the hospitals that do offer OB services, we are going into these rural areas and saying, hey, how can we help you be successful if you are struggling? Is it a staffing issue? Is it financial? Is it billing and coding? And so really working with them to make sure that the operations and the financial sustainability for these OB services is working. Because we want to keep as many of our OB facilities open for as long as we can and reduce the number of OB deserts. So we will offer, evaluation of staffing models, clinical competencies, workflows, payer mix. The scale is pretty wide of what we're going in, but we are really breaking it down to making sure that they are actually working to the level that they should be and getting everything that they need. So this is just an overview of the different areas that we really look at. So we look at the data collection, we look at the volume, staffing, call schedules, workflow. We're looking at the clinical operation. We're making sure documentation is in line with what it's supposed to be. There's safety protocols, readiness for emergencies for these women that present, transfer policies as well to higher levels of care. Then we're looking at the financial sustainability. We're looking at really taking it and looking from a gap analysis. We're seeing the strengths, the vulnerabilities, the risk, and where we can improve. And then we put it into an action plan. So we really work one-on-one with these facilities to say, okay, what are our short and long-term strategies to make sure that we are being effective? And a lot of these may be trainings, it may, be staffing education, webinars, whatever that may be. And then the last piece is our technical assistance. So just being supportive, making sure that we are implementing these recommendations and following up. We don't want it to be a one-time, we just say, hey, these are all the things you need to do, and then we don't follow up with them. So it's an ongoing monitoring process that we are providing. So really, as you can tell, Texas, there is a large maternal health crisis. And we just at RCHI, we are focused on making sure all women have access and equitable care. And whether that's increasing workforce or policy, we are really at the center of making sure we can do everything in our within our scope to reach all of these women. So we're constantly looking for any type of collaborative models, innovative models. So if there's something that's working great in your institution that you think that we could incorporate in RCHI, we would love to hear that as well. But really, we are here to help improve your facility for any of our moms across Texas.
Okay, thank you, Dr. Alvarado. We will open it up for questions now, so feel free to drop those into the chat. I'll give you a couple of minutes. We did have one question come through during registration that I would like to read for you. And that question states, what is the minimum number of deliveries needed in your service area to have a maternal care and delivery program?
We're really focusing on less than 100 deliveries a year. Now, we won't turn anyone away in a rural area that's delivering babies. I don't know what the volume is at your facility, but definitely we would be interested in meeting with you and seeing what you need and what services that we can help provide.
Great, thank you. So I'm going to open the chat. I don't see anything right now. But we'll just give it a couple more minutes because we have plenty of time. But I do want to state, as it has been said already in the webinar, that if you want more information about receiving maternal care, education or training, okay, I will pause because we did get a question in the chat. Thank you, Anne. So she says, are you partnering with hospitals regarding the Rural Health Transformation Program funding that will be released by HHSC in 2026?
I love this question because our Archie team just had our strategic planning meeting on Friday, and we are planning to do as much as we can with this program funding. So we would love to be the main contact for anything rural regarding this. And so all of our teams across Archie, we're looking at that. But maternal health is a big piece, especially in the telehealth AI area, remote patient monitoring. So absolutely, we are planning on partnering with hospitals for this in 2026.
Thank you for that question. Okay, so as I was saying, if you would like more information about maternal care training for your rural facility, you can reach out. I believe, do you? Yes. So Dr. Alvarado's email is on the screen right now, so you can contact her. If you're currently receiving assistance and you have a technical assistance coordinator with the rural engagement program, you can also reach out to them and they can make a connection as well. If you for whatever reason, lose the email, but we would be happy to make that connection for you. Okay, I did just receive another message, and I'm going to read this to you as well. Um, I'm the brand new executive director of the Rural Whole Health Coalition serving Central Texas counties. We have 0 hospitals that have OB departments in Bastrop and Fayette County. I would love to partner with you all for this training. Okay, so absolutely, I would be happy to make that connection when we are offline, and I'll do that following this webinar. Thank you for reaching out.
I completely forgot to mention this is state funded. So the service, the training is completely free for your facility. So the mannequin that we leave the Mama Natalie, it is left at your facility, no charge. And then all the equipment we bring. So it's no cost to your team.
And we have another question that says, we've had an offer to train staff at a larger facility, but do not have access to legal partnership. They would like a legal agreement. Would that help be available?
Could you expand on that a little bit more? An offer to train, someone wants to come to your facility to train, or they want your facility to go train?
Amanda, would you elaborate or unmute? It sounds, I interpret that as their staff would go to the larger facility to train, and I guess there would be some, legal things that needed to be signed. But if you'll elaborate on that, you can also just unmute. We'll give you a minute. No, I'm sorry, we can't hear you. Let me find you and see if I can unmute you. Okay, I'm not able to unmute you. I did request that you unmute, so I don't know if that will help you or not. I apologize.
Can you hear me now?
Yes.
Okay, thank you. Um, so we need to train nurses, but we only run about 100 births a year. And we were going to go to a medical center in Odessa, but they asked for a legal agreement so that the nurses would actually be able to participate in the care. And I did get a legal agreement, but honestly, I am not a lawyer, and it was not one that I could easily modify to where, you just fill in the name of the hospital that's sending and the hospital that's receiving. And this was to keep them from being, I guess, liable from any injury that might happen at their facility.
So we don't specialize in the legal side, but we would be happy to help provide training for your nurses directly.
Oh, great. Okay, how would we do that?
If you just, we can set up a meeting so I can understand a little bit more what your team needs. But for OB, I would
Okay, I'll send you.
definitely help. Okay.
Thank you.
Yeah, thank you for unmuting. Okay. Any other questions? We still have a little bit of time. So it's exciting that we have made hopefully a couple of connections and maybe some training will come from that. So I think if we don't get another question, I think that we will go ahead and adjourn, but please do reach out if you think of something or if you don't know if you would be eligible, just don't hesitate to ask. We would be happy to have a conversation around that and make connections. But we thank you for spending your time with us. We hope you have a wonderful Thanksgiving week, and we look forward to, we will not have a December webinar, so we look forward to seeing you on our January webinar. And Dr. Alvarado, I want to say thank you for sharing information about your program and being on our webinar today. We appreciate you. All right, bye everyone.